Okay, so we have here your anti-nuclear antibody. So when speak about the anti-nuclear antibody is the antibody directed towards the whole nucleus or the nuclear component. And this anti-nuclear antibody could be in the form of IgM, IgG, or IgA antibody. The following here are example of anti-nuclear antibodies. So we have antibody to your DNA that may be in the form of anti-double-stranded DNA, anti-native DNA. Confirmatory tests here for identification of your anti-double-stranded DNA is by your reticulocele. So this is hemoflagellates, wherein the kinetoplast that contains here the double-stranded DNA. Then we have your antibody to your histones. This is being induced here by your that's one by your drug, cytralosine hydrochloride or your procainamide hydrochloride. This antibody includes your anti-H1, anti-H2A, H2B, H3, and your H4. Third one, we have your antibody to your multiple antigens. So we have your anti-SM or anti-Smith antibody. So this is an acidic nuclear antigen extractable here by an aqueous solution. And this is very specific for the SLE, along with your anti-double-stranded DNA. Another one, we have your anti-DNP deoxynucleoprotein. This is also called here your LE serum factor. And this is responsible here for the LE cell formation. It's being induced in vitro. In vivo naman, that could be induced here your LE formation, LE cell formation could be induced here by your serocytes. The fourth one, we have your anti-RO or the anti-Robert or the SSA. So seen here the patients with SLE dermatitis in the patients with the neonatal SLE. Then we have your anti-lane or the soluble substance B that is seen in patients with the SLE plus patient with Sjogren's. So only if you have here the presence of both the SLE, SSA and the SSB, that signifies a mild disease. But if you have here only the SSB, that signifies your Sjogren's. And lastly, we have your anti-nuclear antibody, anti-nucleolar. Okay, this is your antibody against your 4,6S ribonucleoprotein. Okay, we have here the anti-nuclear antibody testing. So basically, you are the testing here for the anti-nuclear antibody presence in the serum of the patient. So this is a type of the fluorescent anti-nuclear antibody testing in the form of your indirect indirect fluorescent immunoassay. Indirect, you're detecting for the antibody with that. Okay, since you're detecting for the antibodies, so it become indirect. So your sample contains here, the serum contains your anti-nuclear antibody. The reagent here in the form of your antigen containing here the mouse kidney cell or your human epithelial cells or the hepto cell. Then you add here your anti-human globulin labeled with your fluorochrome. And then for the read the result here microscopically with your fluorescent microscope. And then try to observe here the different patterns. So the pattern of the result could be in the form of number one, homogeneous pattern. Homogeneous pattern characterized here by the entire nucleus here try to be stained or try to flourish. So this related here to the presence for anti-double-stranded DNA, anti-native DNA, anti-histone, and anti-DNP. Another pattern we have here the peripheral marginal rim. So ang kanyang margin lang. So, ang nagpo-fluoresce lang dito is dito na side. Pag entire nucleus here, so that's homogeneous. Kung dito lang sa margin ng nucleus natin, membrane, so na become here your peripheral rim or your marginal. So, nucleus membrane, try to fluoresce. Okay, while the central area is poorly stained or not stained at all. So, ito lang nagpa-fluoresce, which try to expand to the cytoplasm. And this was related to your anti-double-stranded DNA and anti-DNP. Your speckled pattern, on the other hand, characterized here by, so pang ito nucleus, so may mga small dots dito. Okay, so that's your grainy pattern with the numerous small dots. We try to fluoresce, but the nucleoli do not fluoresce or do not, it's not stain. Again, that one is related to your anti-SM, anti-Smith, and anti-histones. Another one, we have the nucleolar pattern. So what is being saying for that would be the nucleolar. So that's few round smooth nucleolar fluorescence, the try to fluoresce. and is related to your anti-4,6S RNP. Okay, another pattern here, we have the centrometric pattern, centromer pattern, characterized here by the staining of the centromer chromatin. This is associated with your CREST or the following. That's your calcinosis, rain phenomenon, esophageal dysmotility, sclerodactyly, and we have also here your telangiectasia. And we have also the screening test here for anti-nuclear antibody. You could use here also your autoimmune immunofluorescent assay. But of course, the confirmatory test would be your FANA, fluorescent your indirect fluorescent immunoassay. We have here the summary of your anti-nuclear antibodies. So SLE would be characterized by the appearance of your anti-nuclear antibody in the form of your double-stranded DNA and anti-Smith antibody. Your PSS would be the presence of your anti-nuclear antibody and anti-SC1I. And we have polymyositis characterized by the anti-nuclear antibody in the form anti-Jo1. And we have also here the rheumatoid arthritis will be characterized by the nuclear antibody plus the RF, rheumatoid factor. Okay, other laboratory tests, hematologic here would be, again, anemia in the form normocytic normochromic. We have also the lymphocytopenia, thrombocytopenia, and antibodies here try to bind with your red cell membrane, could be identified by your direct antiglobulin tests, positive for that. And then we have also here the presence of your antiphospholipid antibody could be identified by your coagulation tests with an increase in your prothrombin time, activated partial thromboplastin time. We have also here the kaolin clotting test is also positive for that. Okay, for the treatment, we have here different drugs. So we have in the case of your acute fulminant lupus or lupus nephritis, you could give your corticosteroid to the patient. In the case of the skin lesion, you could have here the anti-malarial drugs, hydroxychloroquine, chloroquine, and many others. For arthritis manifestation, you could give here your aspirin anti-inflammatory drugs. And we have also, you could use your other drugs, but be careful with this one because again, this one try to suppress the bone marrow. And that would also here to decrease blood cell production. Okay, the next topic we have here the RA or the rheumatoid arthritis. So rheumatoid arthritis is a chronic multisystemic autoimmune disorder characterized here by a progressive inflammatory process made up combination of systemic, symmetric, and erosive arthritis of the peripheral joints with an internal organ involvement, including your heart and your lungs. So the mean incidence here would be 35 to 50 years old, and it's much higher incidence here among 3 times higher incident in the female population compared to the male populations. Okay, we have the risk factor, we have old age, and we have also here the HLA-DR4 haplotype. For the complication, death here may be related to your atherosclerosis. Okay, for the manifestation of your rheumatoid arthritis, divided here into 3. The first one, characterized by initial synovitis or increased accumulation of the synovial joint fluids because of the primary etiologic agents. Followed here by the series of immunologic events result here to your initial inflammatory reactions. Third one, the conversion of your inflammatory actions to your proliferative destructive tissue process. Okay, we have your signs symptoms prodromal before the typical signs symptoms manifestation of the RA. It's characterized here by non-specific signs symptoms like fatigue, anorexia, generalized joint pain, and later on develop here generalized joint pain, so non-specific pa siya. But could have your extra-articular manifestation characterized by weight loss, subcutaneous nodules in your joints. We have also vasculitis and the typical na Felty syndrome. The Felty syndrome is the manifestation of the RA characterized by a complex of the chronic RA with a combination of your splenomegaly, your anemia, your thrombocytopenia, and we have also here your neutropenia. Okay, so we have here the American Rheumatism Association. Try to list here the 6 criteria for you then to diagnose someone to have here the RA. all you need to do, all you need to have here is 4 out of 6. So the first one we have here, the morning stiffness with the joint pain here. We try to last here during early in the morning. We try to last for 1 hour. Second one, we have the swelling of your joint tissue here, which involve 3 or more joints. Which involve here the proximal joint, the interphalangeal, metacarpophalangeal, and we have here the wrist area or the hand joints area. Third one, with the presence of your symmetric arthritis, characterized here by the pain in your joints here, which are involved here the same joints at the same time. Number 4, subcutaneous rheumatoid nodules. And the fifth one, we have here the positive for the rheumatoid factor. And number 6 should have here the X-ray evidence of the erosion presence in your joints area. Again, you just need to have your 4 out of the 6 here for you to consider here to be positive for the RA. Okay, laboratory diagnostic test here. So we have here the serum iron and the TIBs are both decreased. ESR increased because this one is inflammatory reaction. ESR is one of your active phase reactant. Then serum electrophoresis characterized here by increased gamma region, with the albumin having mild to moderate decrease in the level of your albumin. Immunologic manifestation, so the patient positive for the RF, the presence of your anti-CCP antibody, anti-nuclear antibody, and we have also here the characteristic decreased complement levels. Okay, so we have here the immunologic manifestation. So the earlier stage of the rheumatoid arthritis characterized here by the proliferation of your CD4, CD8 positive cells in your synovial cell lining, and eventually also try to allows the attraction here of your phagocytic cells which try to accumulate on that area. Once they try to accumulate in that area, try to cause here inflammatory reaction that eventually result here to the formation of your panos. The panos here is a mass of the cell which try to accumulate in your joint cavity or space, which eventually result here to the inflamed area. Then followed here by the release of your pro-inflammatory cytokines, which includes interleukin-1, interleukin-6, 8, 15, and 18, plus your tumor necrosis factor alpha, which try to further responsible here for the inflammatory reactions. And next one, we have here the release of your collagenase and other tissue destructive enzymes by your synoviocyte and chondrocytes of your joints, and eventually result here to destruction on that area. And result destructive process result here to destruction of connective tissues, joints, and bones in that area with a classic arthritis manifestation. Okay, we have here the test for your rheumatoid factor. Rheumatoid factor here is an IgM that's trying to react with the IgG antibody. So, you try to trigger here the immune complex mechanism of your hypersensitivity because again, you have your RF as your IgM, then IgG antibody for immune complex, so it deposits here in our joints. But the problem with the RF, this is non-specific because RF, rheumatoid factor, could also be seen here aside from your RA. Could also be seen in other disorders like, for example, your IM, in your hepatitis, and even in your pulmonary tuberculosis. We have here the test for your RF. So we have your RF, the serum, this is your IgM. So we are just needing an agent here in the form of your IgG, pero nakatouch siya sa carrier particle natin. Example for that, we have the Rose-Waller test, wherein your reagent here is your sheep red blood cells as your carrier particle, where try to absorb your IgG antibody as your reagent. And the positive result here will be agglutination reaction. Another one, we have the Singer and Platts test. So almost the same principle here with the Rose-Waller, only that the carrier particle for your IgG is in the form of your latex particle. So the positive result for that would be your latex agglutination or latex fixation. So there are some false positive reaction with this one. So you could use here more sensitive tests for detection of your RF. You could have here your nephelometry, you could have your turbidimetry, you could also have your enzyme immunosorbent assay. Okay, the next one, we have here the CCP or the cyclic citrullinated peptide. So this is being produced here because of your destruction of your granulocytes, and then we have also your leukocytes. So once they're destroyed, they try to produce here the enzyme peptidyl arginine deaminase. This enzyme will try to disrupt here the arginine component of your cell membrane and eventually producing here the CCP. And the CCP is highly immunogenic, which try to trigger your immunologic reaction. So when you produce this one, your body try to produce, since when it's highly immunogenic, your body produce here corresponding antibody in the form of anti-CCP antibody. Anti-CCP antibody is very sensitive, it's very specific compared to your RF, as with the diagnosis of your RA. It's highly sensitive because this antibody has been produced here 14 years, even before the classic manifestation of your rheumatoid arthritis. Again, remember that the RF is, once you have that one, it's also related to other disorders like your PTB, your IM, your hepatitis. But in your anti-cystic antibody is only specific for the RA, rheumatoid arthritis. So this includes here, the anti-CCP antibody includes the following family of antibody: anti-filaggrin, anti-keratin, anti-perinuclear antibody, and anti-SA antibody. Okay, then we have here the pattern of the anti-nuclear antibodies. So, you could have your homogeneous, the speckled pattern here could be associated both with your SLE and the RA. So, a more specific anti-nuclear antibody here for the RA would be the anti-ribonucleic anti-nuclear antibody. For the treatment, you could have your non-steroidal anti-inflammatory drugs that will help here ease the pain for the joint pain. We try to last here 4 to 6 weeks. You could also use here your corticosteroids here for having as an anti-inflammatory drugs. But in the case wherein the joint pain here lasts for more than 6 weeks, then you need to shift the medication to your disease-modifying anti-rheumatic drugs. And lastly, we have here the Cretidia locale. Again, this one was diagnosed for the presence of double-stranded DNA. This one is more specific for your SLE. Okay, I just want to clear that your RA rheumatoid arthritis is different from your gouty arthritis. So your gouty arthritis involves here the defects in your purine metabolism with increased uric acid, but the RA is a type of immunologic disorder. Okay, thank you for this. So this is the end of this topic.